So let's move on to dermatologic lesions. Uh, Tayson, what do you think of this case?
All right. Looks like in the subcutaneous tissues of the digits there, we have some low signal on T1, high PD signal lesions, uh, kind of all over the place. Don't know exactly
Okay.
this could be.
Yeah, and then here we can see them here. They're in the subcutaneous tissues, kind of deep, fairly well circumscribed. And these are passion corpuscles. They're nerve endings. And these are nerve endings that uh, sense vibration and deep pressure. And in some people, they're just very large. So if we look, there's as you all know, multiple structures involved in the skin, and one of the Pesian corpuscles, which sometimes can just become in some people very enlarged and all over the place. And this is what they are, and it's just a variant of the Pas- Pacinian corpuscles that are also called Pesian corpuscles. Okay. So, in looking at malignant lesions, they can be divided into a number of different categories. There's squamous cell carcinoma, which when I was in medical school was not considered malignant, but it can spread aggressively locally, but rarely metastasize. They're typically in older individuals and typically in chronically sun-damaged skin. Then you can also get basal cell carcinoma, which is not considered carcinoma, but like squamous cell, they don't frequently metastasize. They're just locally aggressive. And when I was in medical school, they were called basal cell adenomas rather than carcinomas, but they've been elevated to the carcinoma level in the last multiple decades. Then there's melanoma, which is a much more aggressive malignant lesion. Uh, It can be at any age, but typically late adulthood, and then Merkel cell carcinoma, which is considerably less common than melanoma, but also a malignant aggressive lesion. Then other cutaneous malignancies is dermatofibrosarcoma protuberans, typically middle-aged, and the trunk lesion, leiomyosarcoma, angiosarcoma, then liposarcomas that we've talked about before, and desmoid tumors. And the malignant ones are the ones that tend to be in the abdominal wall. They tend to be a little bit less aggressive when they're more in the peripheral areas. And then there are the lymphomas, of which there are multiple types. They can involve the skin, uh, and yeah, and then other tumors can metastasize to the skin. So, Robert, what do you think of this case?
All right, so we have a 44-year-old female hard mass, and then the subcutaneous tissues posterior to the sacrum. There's the well circumscribed T1 hypointense, uh, T2 bright lesion in the subcu soft tissues. Um, can't tell if it enhances or not. We don't have a pre.
Right. Good. And this was an epidermal cyst, a benign lesion. Okay. Uh, Dan, what do you think of this one?
So 1-year-old with a coccygeal, 31-year-old male with a coccygeal mass for 1 year. It's T2 hyperintense. No other imaging available. Looks like it's possibly some kind of cyst, like maybe a Tarlov cyst,
Yeah.
epidermal cyst.
Yeah. The Tarlov cyst would be more over here
Oh,
in the
yeah.
neural canal. We'll talk about those when we talk about the spine.
Okay.
This is really an epidermal cyst in this particular patient. Okay, Elior.
Okay, 38-year-old male with a left thigh mass. Ultrasound. Looks like a subcutaneous mass. Looks like it's superficial to the muscle on the bottom image.
Yeah, solid, not a lot of no flow in it.
Okay.
And this was also an epidermoid inclusion cyst. And here it really looks very solid, rather than what we'd typically consider as a cystic type lesion. But histologically, it was an epidermoid inclusion cyst filled with epidermoid cells. Okay, Tayson.
All right, 32-year-old female. Guess we're looking at that lesion there, just adjacent to the coccyx. Looks like it's fluid filled. Yeah.
And this turned out, when it was removed, was a bursitis, coccygeal bursitis.
Okay.
Okay, Robert.
All right, so we have a 22-year-old female, mass for 4 to 5 years. Again, in the subacute soft tissues, there's a T1 intermediate and fat sat bright lesion there. Yeah, pretty well circumscribed. Looks like, yeah, it's very superficial.
And it's
No.
really protruding out from the skin surface here.
Mm-hmm.
And it looks like it interrupts the epidermal layer, which we can see here. That's what it looked like after it was removed. And this was a neurofibroma. Dan.
18-year-old male, congenital mass on the left abdomen and pelvis area. So CT with contrast, it's not really enhancing. Has more like a heterogeneous appearance to it. Oh wow, I have no idea what that is. It has some Doppler flow to it. It's got a heterogeneous echo texture. It's superficial. It has, it's probably hemangioma because it has a waveform, a spectral waveform with it.
Yeah, this turns out to be a plexiform neurofibroma in a patient with neurofibromatosis.
Oh.
Yeah, it looks like a very vascular lesion. It's really purple. I would be concerned just looking at this that it could be some sort of a vascular malformation, but it turned out to be a neurofibroma. So another classification for masses, they can be mesenchymal tumors like dermatofibrosarcoma protuberans, lipomas, angiomas, nerve sheath tumors, malignant fibrous histiocytoma, liposarcomas, and so forth, including nodular fasciitis, which we've talked about in fibromatosis. If you look at the lesions of the skin appendages, you have epidermal inclusion cysts, pilomatricoma, cystadenomas, cylindromas, and syringomas, which occur in their pretty characteristic locations, with pilomatricoma often calcifying. And then metastatic, you can have metastatic lesions, other tumor-like lesions, including myxomas, lymphoma, granuloma annulari. And then you can have inflammatory lesions, which can look mass-like as well. So, Elior, what do you think of this case?
All right, so we've got subcutaneous mass along the anterior leg. On T1, it's the top left image looks low signal. Yeah, is that contrast enhanced in the middle image on the right, or?
I think the contrast is the lower image on the left and the right image on the
Oh, right. Okay. Yeah. So there is contrast enhancement. Um,
Yeah, again, I'd
yeah.
like to have a T1 fat sat pre before I really made that determination. If it is enhancing, it's only peripherally enhancing. There's no real central enhancement. So the bulk of this lesion definitely is not enhancing.
Hmm.
Yeah.
I mean, given the amount of time, 2 to 3 years, I wouldn't think an infection.
It's a young kid. It's
Yeah.
in an area where they're very prone to get trauma.
Right.
And this
Okay.
is calcinosis cutis, which my guess is, at least in some cases, is probably a result of subcutaneous hematoma formation, and then the healing, and uh, you know all here part of scarring, and the resorption, the incomplete resorption of the hematoma, and these typically will have calcium in them. Okay, Tayson.
All right, 81-year-old female, right thigh mass, rule out neurogenic tumor. So this looks like a hypoechoic lesion, kind of heterogeneous signal, and some internal vascularity. Um,
A little bit of through transmission.
yeah,
Okay, so this was a nodular hydranoma. They're rare benign skin lesions. Yeah, and can be variable sizes. And they can be mixed or cystic, variable T1 and T2 characteristics. I think the one thing that you probably get from this that I think is important is that occasionally you can make a relatively definitive diagnosis based upon MR characteristics, but the vast majority of skin lesions, I think that you really can't make reliable, definitive histopathologic diagnosis based just upon MR characteristics. And I think most of these lesions, you really have to have pathology. You have to have tissue to really make a definitive diagnosis. Robert, what do you think of this one?
All right. So in the subcutaneous tissues, anterior looks like the knee or so, somewhere around there. Distal thigh. There's a well circumscribed T1 hypointense, fluid sensitive bright lesion with peripheral enhancement in the superficial soft tissues there, subcutaneous fat.
Again, it's protruding beyond the surface of the skin.
Mm-hmm.
Oops. No, this was just another nodular hydranoma. Okay, Dan, what do you think of this case?
6-year-old boy with a hard purplish subcutaneous lesion in the right upper arm. You can see this subcutaneous round lesion that's got well-defined borders and a heterogeneous echotexture and posterior acoustic shadowing. Okay. Yeah, it's avascular. I feel like it's going to be a benign lesion. Okay.
So this
Never
is
heard of it.
matrixoma. So this is basically a hair follicle mass. Okay, benign. All right, Elior.
Here we have a 6-year-old girl, soft, reddish, palpable mass for 2 years. On the MR, this mass in the subcutaneous soft tissues, well defined, like lobular border, increased signal on T2, low signal on T1.
Okay.
Ultrasound, we see some flow in it. Yeah, I'm not quite sure.
This is a myopericytoma. Again, it's part of the organelles of the skin. Usually benign, rarely malignant, and yeah. And you can have smooth muscle tumors, benign or deep leiomyomas, malignant leiomyosarcomas, and then they can also get pericytic, perivascular type tumors, glomus tumors, and myopericytomas. And just, okay. Okay, so what do you think about this? Let's see, who's up right now?
I can help.
Let your back and go. Looks like a
Okay.
circumscribed mass there in the cervical soft tissues. Looks like it's homogeneously hypoechoic with, yeah, a lot of vascularity through transmission.
Oh, here's a similar lesion. This is on the back.
Yeah, pretty homogeneous, well circumscribed. Some internal low signal foci there.
So this is dermatofibrosarcoma protuberans. Notice its margins are very sharp. It is protruding a little bit here. Relatively uniform. This looks like it's a low aggressive type lesion, but this is a sarcoma. So again, the MR tissue characteristics can be very deceiving in skin lesions. So again, I urge you to have a low index of suspicion for malignancy and getting tissue diagnoses.
Okay.
Robert.
All right. So here we have a 23-year-old female, subcutaneous soft tissues. It looks like there's, a focal area of T1 decreased and fluid sensitive bright signal. Not a whole lot of mass effect there. That's right where the skin marker is.
Unfortunately, they've deformed it by putting the skin
Yeah.
marker right over it. And
Yeah.
this was another dermatomyofibrosarcoma in this area. Okay, Dan.
40-year-old male with axillary irritation and mass after running, rule out lymphadenopathy. So protein, oh, no, that's T1. T1 pre and post contrast. T2, my bad. T2 pre. That's
Right.
bad. There's a lobulated mass on the T2 sequence with a heterogeneous or increased signal within the mass.
Right.
T1 post shows I don't have a pre, so I don't know if it's actually enhanced or not, right?
Exactly. We don't. So it's inhomogeneous. The margins are relatively sharp, though superiorly here we kind of lose the margin definition.
It's probably that Hydra. I don't remember the exact name of it, but if I see it, I would probably guess. Oh no, not at all what I thought.
Yeah, just a second here. Let me see if I can fix this so that we can see. Okay. Okay. So here's that. Okay. So here's the T1 pre and here's the T1 post.
Okay, so there is some peripheral enhancement. It seems maybe a little bit of internal enhancement as well.
Yeah, a little bit. Right.
Mm-hmm. So I think I saw one that said it was like a melanoma. What lesion is predominantly dark T2, bright T1? brighter in T1 fat sat with some peripheral enhancement.
Yeah, the key thing here is that what masses can be bright on a T1 weighted image that don't have hemorrhage in them. So what kind of soft tissue material actually can have a short T1 on MR examinations, and that's melanin.
Okay.
And so
Yeah, obviously.
this inhomogeneous appearance like this on a non-contrast enhanced T1, that this is a very characteristic appearance of a melanoma. It's bright. Very few other soft tissue tumors are bright on T1 weighted images. And this doesn't really have the kind of characteristics that we see in hematomas. This looks like a solid lesion. Looks like a little bit less on the T1 post because we window it differently on the T1 post. So there's really not a lot of enhancement in this particular image, maybe a little bit, but this is characteristic of melanoma. Yeah, and this patient, we asked if the patient could have had melanoma, and they actually came back saying yes, the patient had a melanoma resected 7 years before. So that's very characteristic of melanoma. Okay, Elior.
A 68-year-old man, growing mass. So here again, we have a mass that is T1 bright. We have T1 at the top there.
Here's a T2.
T2, yeah, heterogeneous, well circumscribed, but mostly bright on T2.
Yeah.
Yeah, so on the sagittal views, we see that it's
Yeah, these are post-contrast.
okay. So there could be some contrast enhancement.
Some areas may be enhancement, some areas where it's probably not enhancing, but we don't know since we don't have a T1 fat sat pre.
Well, if it's T1 bright, I would think, I mean, could be blood products, could be a hematoma.
Okay.
Um,
Doesn't really have the usual characteristics. It doesn't have the usual architectural structure of the hematoma, but absolutely you'd have to be concerned that it could be some sort of a hemorrhagic mass. And this turned out also to be malignant melanoma. Okay, Tayson.
All right, so we have a 7-year-old female with a skin mass. It's like a subcutaneous, well circumscribed lesion. There's a little linear focus of increased signal intensity internally on the T1 and some high signal there in the T2 and the surrounding tissues there. Just a stir?
I think there's a T1, and this is, I think, a PD fat sat.
Okay. It looks like low signal on T1 and kind of has edema inside of the lesion there. Margins look kind of irregular on that image on the left. Doesn't.
And a very kind of odd appearance on the T1 fat sat post.
Yeah.
Pre and the post. It almost becomes iso intense to fat.
This is area of fat necrosis.
And this was a Merkel cell carcinoma. But, I think the fat necrosis is reasonable. But again, it's a non-specific lesion, so you really need a tissue diagnosis here. This is much less common than melanoma. Okay, so those are a few skin lesions. Let's go on to soft tissue masses of uncertain origin. Uh, Robert?
All right. Along the peripheral aspect of the tibia, it looks like there's a T1 uh, intermediate and fluid sensitive bright lesion there. Um, it's not very well defined. Yeah. Uh, yeah, it looks similar on the these images as well. A little more heterogeneous on the image on the right.
T2. Yeah,
Yeah, the T2.
sagittal. Yeah. Here's an axial T2.
Yeah, here along the anterior medial aspect of the tibia, there's that again a mass. Looks like there's some irregularity of the cortex of the tibia.
Yeah, maybe a little bit, though. I don't really see definite. Maybe there's a little erosion here, but it looks like the cortex is still grossly intact.
Mhm.
So, what would you want to do with this?
Uh, get some tissue sampling at the very least.
Yeah. And this turned out to be a ganglioneuroma. So this was a nerve cell, probably nerve cell uh, uh, lesion, but again, it's not really clear what the tissue origin is of this. Also called an extraadrenal pheochromocytoma. Okay, Dan.
61-year-old male with a 4-year history of a leg mass. I think those are a T. Is that a CT? Looking at. Okay, those are CTs with these, hypoattenuating lobulated masses.
I think this is CT with contrast.
Oh, that is? Okay.
Yep. So there you can see the contrast in the vessels, and then here are these masses, pretty uniform, low density, very sharp margins. So what do you think this is?
It looks somewhat cystic,
Okay,
but
and here we see no enhancement at
yeah.
all. Here is if you go to pre-contrast and post-contrast, this is what you see.
Yeah, so no contrast enhancement.
So what's your thoughts?
I don't think it's like a interosseous lipoma, but I mean, I guess it could be.
Could be.
And could be some kind of like cyst, but I'm not sure exactly what it is.
Yeah. So this is very characteristic of a myxoma. You don't really get cysts in muscles.
Yeah.
You know, you can get tears in muscles that can fill with fluid sometimes, uh, but not cysts. So what looks like cystic lesion inside of muscle is a myxoma until proven otherwise. And myxomas are low-grade malignant lesions. So this is really a lesion that has to come out. So just be aware that with MR, they can look very similar. They can look just like cysts with no enhancement and no tissue within them, or they can have actually more solid characteristics within them on an MR as well. But if you see what looks like a benign cyst in a muscle on MR you have or CT, you have to be highly suspicious that you're dealing with a myxoma. Elior.
Okay, 50-year-old man, incidental finding. CT at the top left, we see this intramuscular mass. It's hypoattenuating. On the MR, top right, it's a T1. It's just T1 darker than muscle. T2 in the middle, just bright, homogeneous, well circumscribed. Below that, contrast enhanced, just heterogeneous contrast enhancement internally. Yeah, I'd be worried about. Okay.
That's what it looks like.
Looks like
Enhancing components in there, probably the enhancing components there. And this is another intramuscular myxoma. So here again, it looked kind of like the other myxoma on CT. On MR, this one had much more complex signal within it with some enhancing areas. But again, myxomas can look completely cystic on MR, or they can have very complex internal structure like we're seeing here. This makes it much easier. This is clearly a lesion that you'd be concerned about when you see the MR here. But if it looked just like a cyst with MR with no enhancement, you have to be equally concerned if it's within a muscle. So 82% of these are in muscles, 50% are in the thigh. A lot of mucinous comes. So you can't have fat around these, but okay. Tayson.
All right. So it looks like anterior to the lateral femoral condyle and Havas fat, we have this multilocular cystic appearing structure.
Okay. Oh, so this was another myxoid tumor. If you just saw this, you'd say, well, it's just another multiseptated cyst around the knee. We see them all the time at the origin of the gastrocnemius tendons, but this is not a typical location for seeing these. It's not an infrapatellar bursa. It doesn't look like typical scar tissue here, so this is another lesion that you have to be suspicious of, though myxoid tumors in fat are not that common in my experience, but this was one.
Okay.
Okay, Robert?
All right, so we have a 71-year-old female with rule out right lower extremity venous insufficiency. And it looks like with compression there on the right image, there's a non-compressible structure there, kind of heterogeneous in appearance. Here it looks more mass-like. There's some internal vascularity, so I don't think it's just thrombus. Yeah.
There's the MR.
A lot less subtle on the MR. There's a big mass that, comprises a lot of the lower leg, and it's heterogeneous in signal. Some cystic regions in there.
And some areas that are bright on T1 weighted image, probably in this case hemorrhage, rather than melanoma. And here we can see a very inhomogeneous. So this is 2.1.11. This is 6.6.11. So actually increased over time, maybe some central areas of necrosis. And this was a synovial sarcoma. The one thing to remember about synovial sarcomas is they do not come from the synovium. So that's a misnomer. So they tend not to be associated with synovium. So these, again, are soft tissue tumors of unknown tissue origin, but they are malignant tumors. And okay, so what do you see here? Same patient. Robert?
Yeah, so it looks like they've undergone, a total
An
above the
amputation.
knee.
Yeah. Yeah, so they ended up doing an amputation. So synovial sarcomas are not rare. They're maybe 10% of sarcomas. They tend to have calcifications in them, which can be helpful. And when they present, they tend to be large. Yeah. And very heterogeneous. Ugly. Once they get large enough, they become kind of ugly looking. All righty. See, Dan, what do you think of this case? An old study.
Looks like a T1 pre and post contrast study with an irregular shaped hypointense mass, which looks like it's eroding the. Not sure if that's the cuneiform and part of
Eroding the
the
cuneiform and the metatarsal base.
head.
Right.
Yeah, it has some enhancement, post contrast enhancement. There you go.
This was another synovial sarcoma. Okay, Elior. Normal or abnormal?
Not normal.
Okay.
Yeah, certainly. Yeah, this mass in the right kind of inguinal region, very irregular margins. Yeah, heterogeneous.
Yeah, kind of smudgy in the middle here.
Yeah.
Yeah, and
Yeah.
and then T1 weighted coronal. These almost look like hematomas. In this case, it's on either side of the hip joint because it has kind of a smudgy appearance inside, a little bright around the periphery.
Yeah. Yeah, I'd be worried about this.
Yeah, this turned out to be a synovial sarcoma as well. So, as I was saying before, beware of trying to be a hero and making a tissue diagnosis based upon MR criteria. These masses tend to be very variable in how they appear on MR studies. So you just have to have a high index of suspicion and if in doubt, get a tissue diagnosis. Okay, Tayson.
All right, 65-year-old female with knee mass. The subcute tissues are kind of blurry here.
Right. So what do we do here? Infrapatellar.
Ultrasound is kind of blurry too, but there's an uptake there in the distal femur on the left.
This is from Brazil, right? A lot of uptake on the bone scan. The MR is a little better, still a little bit of a problem.
Yeah, so there's this heterogeneous low signal mass there anterior to the ACL. Actually, it kind of goes posterior to it as well.
Yeah.
Some sort of synovial mass there.
On the T2, it's a bit more inhomogeneous. Here I think this is probably stir image.
Lobular margins and inhomogeneity internally.
Okay. So what do you think? What are you worried about?
Some sort of malignant. Yeah, okay.
So this was a sarcoma. In this case, what's called a clear cell sarcoma, very similar to a Ewing sarcoma. So again, a malignant lesion. Alrighty. Robert.
Yeah. So we have a 16-year-old female with a soft tissue mass. And yeah, in that posterior compartment of the leg, there's a heterogeneous mass. Pretty well circumscribed on both images there, but heterogeneous for sure.
What do you want to do?
I want to biopsy it and get some contrast. Yeah, it looks pretty large and
It looks like on either side we have these linear structures that come into it.
not sure is yeah. Yeah, it looks pretty bright. Is that enhancement? Oh yeah. It looks like there's some metastatic disease in the chest and vertebral body there.
Yeah, this turned out to be a soft tissue Ewing sarcoma, which are pretty uncommon. But yeah, with metastatic disease. Okay, Dan.
29-year-old with a slow growing mass. So looks like
We have this same linear structure kind of going in and out of this particular lesion.
yeah, looks like it's got a heterogeneous it's got some T1 bright signal, and it looks like there's some internal enhancement.
Yeah.
Probably another Ewing's sarcoma, soft tissue mass.
And here we can see it's very,
Yeah.
here it looks like it has multiple components to it, maybe some cystic areas within it.
So, oh wow,
And this was a soft tissue aneurysmal bone cyst.
didn't know that was a thing.
Yeah, a very rare commodity. Elior.
Okay, young woman with joint stiffness. On this elbow X-ray, we see these, these calcifications in the soft tissues running along the muscles.
What's your thought?
I remember we had a case of sparganosis that looked like this.
Yeah, this one is from Brazil. Maybe a different organism, but still, this really looks like a parasite, right?
Mm-hmm. Yeah.
There we can do the soft tissues. And I think they're more likely to eat pork in Brazil than uncooked snakes.
Oh.
And this is cysticercosis. And yeah, there's typical appearance of the Tinea solium. Okay. Well, so we finished here. So this is kind of a review of soft tissue tumors. We'll move on to another topic. Tomorrow. Okay, so I'll see everyone tomorrow. I think Dr. Yagutis will be joining us again tomorrow. Any questions?
Thank you.
Thank you.
Thank you.